thank Merck, who is hosting both our here location, and Ray Mitchell, who is the Director of Business Development here, who so kindly allowed his staff to work to put on the webcasting and video recording of the session. So this is our first attempt in having that done for people who were able to make the meeting live, and also the recording for posterity's purpose. So a couple of housekeeping items. Next meeting will be September 24th at 5:30 at the terminal station. We will have Dell come in to talk about big data, which will actually cover a number of different topics when it comes to unstructured data, storage, and data access, data backup. A couple of quick other items. We'll be doing logistics in October, which will cover a number of different things from application development through local logistics organizations, statewide and regional logistics conversations as it applies to technology. The group is obviously a member-driven organization. For those of you who are for your first time, welcome. For those of you who've been to a number of meetings, the meetings we're having, obviously, TAG at a statewide level has been having Heather come down and help us get the group started. Hopefully, come the first of next year, we will move to a member-run organization. Anyone who is interested in helping drive the direction of TAG Middle Georgia, please let Heather or any of the other, myself or any other board member know, as we are looking for additional board members to join the group to help drive that Middle Georgia conversation. There are a number of chapters, which I understood today. There actually will be a TAG Athens starting later this year that will join Columbus, Augusta, and then the main chapter out of Atlanta. So today we want to talk about health informatics. We have a number of speakers coming in today that are local who work within the health informatics, either from education or actually in the healthcare systems. Our first presenter today is William Abagnale, who's the Chief Information Officer of Central Georgia Health Systems. He's been in this role since February of 2009, and prior to joining Central Georgia Health Systems, he served as CIO and Vice President of Facilities for Cape Fear Valley Health Systems since August of 2001. In that role, he was responsible for all the information technology resources serving the entire health system, as well as facilities development and engineering. For this appointment, he was the Vice President and CIO of the Healthcare Systems of Augusta, Georgia, for 4.5 years, and during his tenure at the University of Health, he was able to administratively responsible for the laboratory and radiology departments. So let's welcome William Abagnale to discuss health informatics.
What I'd like to do is talk about sort of the current state of healthcare informatics. In particular, because healthcare has always had a reputation for being slow to adopt information technology to support its operations. We're at a place right now where we actually have the technology in place to do it, but we really can't talk about these things which are driving today's operations without giving some history, some background, some context. And so what I'd like to do is talk about how we got to where we are today. And this really is going to cover about 50 years of healthcare IT development, and I understand I have about 5 minutes to do it. And you're all familiar, a hot, dense state, the big bang. The problem is, there was no big bang. There was a whole bunch of little bitty firecrackers. So back in the 60s, and to be perfectly honest, I've been in healthcare since in the 60s. So back in the 60s, we used those big old mainframes, and the first application that was widely used was patient registration and billing. And it was simply the process of collecting name, address, telephone number, the typical demographic stuff, and charges and sending out bills. But at the end of the day, we printed information and we put it into the chart, the medical record. And you're all familiar. If you've ever been in a hospital, there's a nurse station, there's a little folder in there, and that's all your information. If you go to the doctor's office, they always walk in with this cute little manila folder. So all of this is printed out, goes into the chart. Now, over the years then, we began to develop lots and lots of applications. For instance, the first one that came up after that was probably the laboratory. And it was, in fact, exactly that. But it would do the same thing. If you notice, in fact, in the slide, every one of these applications has its own database. They're not talking to each other, not touching. The reality is, we would collect data in patient registration. The patient would go to the laboratory, they would sit down there and ask the same question. Name, address, telephone number. And sometimes they'd have typographic errors. In each of these applications, the same thing would occur. Separate databases, separate applications, no discussion with each other, and the only thing in common was they all printed their stuff out and put it in the chart. What's really, really scary is this is still happening today in many hospitals, where a patient's in the hospital for 5 days. After the first day, they get a cumulative lab report of all their results that occurred for that day. Someone runs around the floors of the hospital, grabs a patient's chart, puts that sheet of paper or 2 sheets of paper in the chart. The next day, guess what happens? We print another one, complete cumulative, take out the old one, shred it, hopefully, and put in a new one. So that's still going on today. So we're collecting lots and lots of paper in the medical record. Now, over the years, what began to happen is vendors realized that we're always collecting the same demographic data. So at least we began to develop interfaces where we collect the demographic data once in registration, send some interfaces over there to populate the other systems. The problem was lots and lots and lots of different vendors. And back in the day, there were probably 100 different vendors that would produce laboratory systems, and 30 or 40 that did radiology systems. Clearly, none of this would talk. And the reality is, we still relied on paper, whether it was in the hospital or in physician's practice. Always relied on paper. What began to happen then, realized that we were collecting all this data. Somebody had the idea, well, let's at least, just like we're sort of collecting demographic data, at least begin to send the clinical data into a clinical data repository. So that's what began to develop over the years, probably it was real popular in the 80s, where the laboratory data would go into the medical record by paper, of course, but also then be attached and stored in a database along with radiology. So we began to collect clinical data about the patient. But we still relied on paper, and it was still dependent upon vendors to produce the software and produce all the other interactions. I mean, there was essentially no in-house development from a healthcare perspective of software, always from a vendor perspective. This sort of morphed into what we're beginning to hear more about today is electronic medical records. And what's happened from an industry standpoint is the vendors began to consolidate. So we had radiology, a vendor that produced a radiology system, one that produced a laboratory system, and the larger vendors then would buy these other little companies up and then bring all their software together, try to have a consolidated, integrated electronic medical record. And that's generally where we are today. But still, there are lots and lots of vendors. If you look at hospitals that are 200 beds or higher, there's probably about 6 or 7 vendors that meet their needs. If you go below 200-bed hospital, there are probably 10, 20, or 30 vendors that do that. The bad news is we did all of this stuff, and the doctors still relied on the paper medical record. And the problem with the paper medical record, this is an example of why paper is bad. This is an example of a real patient's chart, not from the medical center, by the way, or not from hospital. This is sort of a classic. If you look at this medication, and this doctor wrote the medication for that. Now, what the doctor wrote the medication for was the D word medicine. How do you say that word?
Droneoaterone?
That's, yeah, right. So the D medication. So now, this thing got put into a paper chart, got faxed down to the pharmacy. The pharmacy read that, and that sure looks like an A to me. And so they picked up and decided it was
Amiodarone?
The A word. Now, so the good news and bad news is that both these medications are to treat arrhythmia, irregular heartbeat. The problem is this medication, the A word, should not be given to a patient if they have decreased lung function, if they're not breathing real well. Well, sure enough, this patient had really, really bad breathing problems. And because they were giving that A word at 400 milligrams, they developed respiratory failure, and eventually they died. That's the type of thing that happens. So clearly, the effort then is to move away from paper charts, to fully use the power of the computer to do electronic medical records and to sort of tie this all together and make things much more safe. That then brings us to this stuff. A lot of discussion today about Obamacare and about healthcare reform. The reality is, healthcare reform started 4 years ago. And it started with all of these acronyms. The first acronym we'll talk about is the ONC, the Office of National Coordinator. This was created back in George Bush's presidency in 2004. The idea was to bring within the executive branch a group of primarily physicians and technologists that would aid and give incentives for people to adopt the usage of electronic medical records. It was, again, an administrative function. It was finally created, mandated legislatively by ARA. And it's basically the head of this was a physician. He became the definer in chief of something we would call meaningful use, which will soon make sense. So, 2009, a bill was passed, the American Recovery and Reinvestment Act of 2009. It is, in fact, the stimulus program.